Good afternoon, friends. I once again, on behalf of Dr. Pragnesh Shah, President, and Dr. Pragnesh Vacharajani, Honorary Secretary of the FFPAI, welcome you to our third session on rheumatology. We have none other than Dr. Abhishek Patil. But please be tuned in. The next week, we have some more interesting information and news for you. We do have very regular webinars on varied topics. And those who have questions, you can please post it on the chat box. And to introduce Dr. Jyotika, Dr. Jyotika Gupta is an executive member and advisor for Spice Route India movement. I welcome Dr. Jyotika. This is the first episode she is joining us. And I request Dr. Jyotika, please introduce Dr. Abhishek Patil for the viewers.
Thank you, ma'am, and thank you for having me in this webinar. So I'm Dr. Jyotika. I practice in Bangalore. And today I want to welcome Dr. Abhishek Patil again. We've already been having his sessions from the past 2 weeks, which have been really popular. And we've spoken about rheumatoid arthritis. So today we will be speaking about and discussing SLE. Dr. Abhishek Patil has done his rheumatology and clinical immunology, and he heads the department at Manipal Hospital's Old Airport Road. He has a keen interest in teaching. He's also a teacher from under the National Board of Examinations. He has a lot of journals and textbook chapters under his name. We welcome you again, Dr. Abhishek. Over to you.
Thank you, Dr. Jyotika. It's a pleasure to be back again here for this all-important session on lupus. And we went through gout, rheumatoid arthritis. Lupus is probably much less commoner of a disease compared to gout and rheumatoid, but probably also something which is much less understood. So I thought we will have a small session on the same thing. And I again thank FFPAI for providing us this opportunity. I'll continue. There is a small mistake in the print that was there. Approach to SLE in a patient, young female. So it's not young male, it's young female because lupus outnumbers 10:1 in females to males. So it's a very common disease affecting young girls of 20 to 40 years of age. That's the common predilection for this disease. And there are various reasons cited. We will go through them one by one. So this is generally how I go about all my presentation. We generally will start with basics of pathogenesis, very simple way, and clinical approach, how to interpret the labs and immunological tests. You see, I'm placing immunological tests after the lab parameters like CBC, LFT, creatinine, because for diagnosis of lupus, these are much more important than ANA. I'll come to that. How is that so? And then treatment, well, we won't be able to do a lot of justice in the small 1 hour time on treatment part of it, but we'll touch upon what is new in SLE treatment.
Yeah. Dr. Abhishek, your video is not visible.
Video is not visible?
Yeah.
Ma'am, the entire screen is not visible, is it?
Video was off.
No, the screen is visible, no?
Yeah, it's fine now.
It's fine, no, ma'am?
Yeah.
Okay.
Screen is visible, but your photo is not seen.
Okay.
Yeah.
Okay.
Now it's fine.
Okay. So I have to bring this small box here, then a small box will remain here. So that should be okay, I feel. Yeah. When do we suspect, we all suspect SLE. So this much we know that SLE is a chronic autoimmune disease. Young female presenting with a rash like the one which is seen in the picture, typical malar butterfly rash on the face, which is itchy, which is photosensitive, along with fever and joint pain. So this is a typical lupus patients that we all think of, we all read in the textbooks. And it's true also in many cases. But you remember that in dark complexions, their mala rash may be very subtle. For example, this young girl walking into the OPD has a full-blown lupus, but see how faint the uh, mala rash is in her. So mala rash is typically erythematous maculopapular rash, and it is obeying all the textbook description of not crossing the nasolabial fold on the sun-exposed area, and it can be very subtle. However, it's a very specific marker for SLE. So when I say specific marker, 90% or more specificity. So 90% or more of those patients with this rash typically have full-blown SLE. So it's something which is very easy to miss. We'll come to the differentials. But this is what sets the tone for my talk today. So that is why it is important to appreciate these group of patients. I feel there is a significant of underdiagnosis and also in certain cases overdiagnosis of SLE. Many times, some people with mild joint pains and ANA positivity, I've been seeing them as labeled as lupus and then treated. And that's what I want to hopefully cover through this small talk. So what basically happens in SLE is there is a genetic underlying predisposition. Many of these patients with SLE have defective processing of debris. So remember this word, defective processing of debris. So our all bodies, we constantly get exposure to UV light and various other harmful pathogens, macrophages, and our cells keep getting destroyed. And when these get destroyed, they undergo apoptosis. They need to be cleared by the immune cells so that these altered antigens don't go and trigger the T and B cells. So that defective clearing is the main genetic risk for as lupus. So all those are cells and tissues which are involved in lupus, such as macrophages, complements. These are all involved typically in clearing of the debris. So that is what it is. Defective environmental factors. I think we all are aware that we typically ask patients to apply copious amount of sunscreen because the UVB rays with 320 to 400 nanometers penetrate into our skin and cause the damage. Then there are obviously some immune regulatory defects. The activated immune system, as I highlighted during rheumatoid talk, is beautifully controlled by counterbalancing T regulatory cells. And when these are defective, you get SLE. And I told why lupus is so common in females, 10:1 ratio in females to males. The main reason probably is hormonal because they have a higher estrogens and progesterones. And unlike male testosterone, estrogen is inflammatory in nature. By nature, it stimulates the immune system. That's one. And there are several other reasons, such as females have an extra X chromosome. So, and X chromosome contains a large number of genes involved in immune system regulation. So when you give an extra dose of this, that also can trigger immune system. And this is called defective X-linked inactivation. Generally, our in all females, one X chromosome is supposed to be suppressed so that only genes present in one of the X chromosomes are, expressed. But this doesn't always occur. Sometimes you can get extra amount of genes coming from a small portion of X chromosome, and that can result in extra immune cell activation. The epigenetic factors, this is where probably smoking has a high risk for about 3 to 4 times higher risk for lupus because it causes a lot of changes in your cell antigens, making them susceptible to recognition by immune system, initially innate, followed by T and B cells, resulting in antibodies and cytokine production. As we know that this is a widespread systemic autoimmune disease. So all this is occurring across our body, hence skin, kidney, lungs, brain, heart, and gastrointestinal system, and practically every organ you can think of is affected. So this is the cartoon which depicts the same thing. As I told, there is a UV rays coming onto your skin, which is undergoing apoptosis. Sorry, I'm having a bit of cough. I'm sorry. Now, this has to be cleared generally by your regulatory mechanism. Sometimes when this becomes defective and there is an excessive antigen presentation, this results in excess activation of T cells. And that's why TB cells, drugs, and cigarette smokes are typically represented as the prominent risk factor for lupus. Then you have genetic factors also, whereas such as those involved in interferon signaling or antigen processing, and this results in innate immune system activation followed by adaptive immune system, that is T and B cells, and then you have development of autoimmunity. So there are over 330 genes which have been described in lupus so far, and the list is ever increasing. So these are not typically a single gene defect. You cannot say that only TREX gene is mutated in lupus. These are monogenic variant of lupus. I recently had one patient, very elderly, about 52-year lady, where I found a TREX1 gene mutation leading to Aicardi-Gouttiere syndrome. But these are very rare. Generally, you have a small contribution by multiple small genes resulting in increased susceptibility of SLE. So typically, these are called polymorphisms. Polymorphism, as opposed to mutations, are present in generally more than 5% of the population. So these are just small variants which results in altered immune signaling. Individually, they are not sufficient, but each of them contributes in a small fraction to the final development of SLE. So these are the various genes that have been recently described, and this is a Frontier Lupus paper, and that describes all kind of mutations that are described in lupus-related genes, including stop codons or missense mutations, and even intronic region mutations. Environmental factors, we all know that UV rays are definitely pathogenic, and typically UVB rays are most pathogenic, and that causes apoptosis of the cells within the skin. And you may ask, why only SLE in some patients? Because we are all exposed to UVB rays, and why don't we develop apoptosis? Because even if there is an apoptosis in us, these are cleared very rapidly. But in lupus, because of polymorphisms, the cells which are supposed to clean up this debris, let this debris accumulate. It's like municipal corporation, which is not working efficiently, leading to accumulation of dirt and debris on the road. And this dirt and debris in turn stimulates lupus, immune cells. And as it is the lupus, because of various, genetic alterations, these patients have a higher tendency to mount an immune response. That's why the risk in first degree relatives is about 4 to 5 fold. In monozygotic teens, it is up to 20 folds, because there is a strong genetic predisposition to SLE, and an estimate say that about 50 to 60% risk of SLE is genetically determined. So this part is genetical, as in case of most autoimmune diseases. Then drugs. These drugs could be your classical hydrolazine, isoniazid, procainamide. These are the things which we all heard of. But now, to be surprising, there are more than 100 drugs now which have been implicated in lupus development. And these are very common use drugs, such as even antacids, like proton pump inhibitors. The risk carried is low, but probably when you look at the cumulative numbers in which they are used, probably they make up a significant burden for lupus also. So one thing you need to remember about lupus is an interferon-driven cytotoxic autoimmune disease. What is that means is there is a cytotoxicity, cell death in lupus, which is elevated, whether it be due to exposure to UV rays or inherent susceptibility. That leads to activation of dendritic cells, the scavenger cells, which engulf this debris and then stimulate the B and D cells, resulting in production of autoantibodies and chemokines. These autoantibodies in turn activate various pattern recognition receptors, resulting in increased interferon production. So the key cytokine involved in lupus that we keep hearing is interferons, the same interferon which is involved in antiviral defense. Now, that being said, we discussed what SLE is. Basically, it's a disease in which there is a defective clearing of the dead cells, resulting in antigenic stimulation by activation of macrophages and then subsequently activation of the T and B cells. Now, the most prominent manifestation, or how the lupus got its name also, or fame also, I should say, is its cutaneous manifestation. And they are present in generally about 80% of patients with SLE, at presentation in about 40 to 50% also, according to various series. The skin lesions in SLE can be specific or non-specific, and the specific lesions are, as you can see in your picture, this can be malar rash, typical acute cutaneous lupus erythematosus, erythematous maculopapular rash on the cheek, and which is photosensitive, which is called acute cutaneous lupus erythematosus. Then you can have subacute cutaneous lupus erythematosus, intermittent, and then chronic cutaneous lupus erythematosus, classified, typified by DLA. So these are very specific lupus-like lesions. When we say specific, generally these lesions among the major autoimmune diseases are present only in lupus. However, it has very non-specific lesions also, such as alopecia. It can have ulcers. It can have bullous disorders. It can have vasculitic rashes, leukocytoclastic vasculitic rashes, and various other manifestations, including Raynaud's and others. So it is important to consider lupus in the differentials of these manifestations, provided other features are present. Now, the most known feature is acute cutaneous lupus. And when a patient presents like this, we generally have no hesitancy whatsoever in calling straight away lupus. You can see the erythematous, you can see the maculopapular rash, you can see the thin scaling which is present on the patient, and it is present on and not crossing the nasolabial folds. And very characteristically in the hands, it spares the knuckles generally. So when it spares the knuckles and occurs in the phalangeal area, that's typically SLE. When you have a rash which is occurring only at the knuckles, it's more likely to be dermatomyositis. So this distinction is important, because even on a biopsy, it's very difficult to differentiate SLE from other autoimmune diseases such as dermatomyositis. Important thing about cutaneous lupus is it's photosensitive, it is transient, it lasts for hours to weeks, and it doesn't develop as soon as you enter into skin. There is generally a 2 to 3 hour delay after you get exposed to sun and then development of the rash. And also, once you remove the sun exposure, it takes 2 to 3 hours to subside at least. So this is a very typical history that you elicit in lupus, which is quite different from what is seen in polymorphous light eruptions or sun urticaria. And approximately 90% have systemic involvement. So acute cutaneous lupus is a very specific marker for SLE. However, it's very important to differentiate this particular thing from various other differentials like melasma. So I've seen a lot of patients being ordered ANA for this thing. The patient has absolutely nothing, just some hyperpigmentation on the malar area. But remember, melasma typically occurs in postmenopausal women. It typically persists 5 years and is not photosensitive, and generally it persists throughout. And that's melasma. It's not generally, and it's never typically very red. Now, even malar rash can look like this, but a post-inflammatory phase. But initially, if you ask the history, typically is red. Another very common differential, I think dermatologist colleagues would know that very well, is rosacea. Remember, it can mimic a malar rash of lupus very characteristically. However, one thing in rosacea is it has this something called telangiectasia in most forms. So telangiectasic rosacea will have this dilated blood channels. This is not a typical feature of SLE or malar rash. So when you find telangiectasia, more likely than not, you're referring to rosacea and not SLE. Then those who live in high altitude can have this ruddy complexion, which is normal for them. Seborrheic dermatitis, patients have psoriasis and can look malar rash, but as you can see, it doesn't respect the nasolabial fold. It crosses it, and it also has this thick grayish white, plaques on the adherent plaques. So it's like psoriasis, seborrheic dermatitis. So greasy looking, scaly plaques are very characteristic of seborrheic dermatitis. Dermatomyositis, generally it crosses the labial fold, as you can see in this picture, and you generally will have other things on physical examination giving away the diagnosis. But important thing to differentiate is the biopsy of this lesion will not differentiate between SLE and dermatomyositis. Both of them have interface dermatitis. Both of them are IF positive. It generally is not possible to differentiate these two lesions on biopsy. That's why clinical knowledge is critical in differentiating many of these lesions. Then you have pemphigus foliaceus. These have a lot of crusting and oozing. So when you have red plaques with lot of crusting and oozing, think of pemphigus foliaceus. And then comes the histology. When you're in doubt, you can biopsy, and typically you can see some interface changes, perivascular lymphocytic infiltrate, and if you put a DIF, it will be positive around the dermoepidermal junction. For a typical acute cutaneous lupus erythematosus, we rarely ever require any biopsy. It's mostly clinical. And also, it has a sparse lymphocytic infiltrate. Then comes SLE, two major forms, papillosquamous forms like this, where it can mimic psoriasis very much. And a lot of even very senior rheumatologists have made this, have burned their fingers when they thought it as psoriasis, treated as psoriasis, and for a good 1 to 2 years, and then later for developing proteinuria and realizing that the patient actually had SLE. So in these patients, particularly female patients developing this papillosquamous soriaform lesions, I never hesitate to check INA. I'll always look at urine. I always look at CBC. Any mild leukopenia, any low platelet count, I don't hesitate in ordering the ANA by IF in this patient. So be very careful about psoriasis diagnosis. If you're in doubt, you can biopsy, and typical biopsy findings will be vastly different between a psoriasis and SLE. SC will have typical dermoepidermal junction changes with plenty of immune deposits. So that's something which is lacking in psoriasis. So in your dilemma, always biopsy. It typically, SLE is a subacute cutaneous lupus erythematosus, occurs in the sun-exposed forms of the chest, on the arm, on the face. It generally spaces the face. It is non-scarring, non-indurated, and photosensitivities. But remember, it is not specific for SLE. It can occur with Sjogren's, paraneoplastic, or rheumatoid, and others. And 70% of these patients have SSA and SSP, and about 20 to 30% only meet SLE. So I have a good number of patients who are having SCLE, subacute cutaneous lupus erythematosus, but without underlying SLE. As I mentioned, drugs like statins, CCBs, ACE inhibitors, hydrochlorothiazide, TNF blockers, all of them, and many of the anti-epileptics like lamotrigine can cause SCLE. So when you have a SCLE lesions, always take a thorough drug history to rule out CCPs, ACE inhibitors, and statins. These are very common causes, and you remove the culprit drugs many times help this resolution. Differentials, as I mentioned earlier, psoriasis is probably very common differential. It typically occurs on the extensor surface, and it has no predilection for sun-exposed areas. and no photosensitivity. So that's very characteristic of psoriasis. Lichen planus can also occur in the similar areas, but one thing about lichen planus, they are very pruritic, and biopsy in many cases does help to settle the diagnosis these pruritic lesions. Obviously, tinea infections can mimic this. I'm sure most of us will be able to pick up with at the maximum activity at the advancing ages, and less common causes like numelar eczema. So when you're in doubt, particularly SCLE, I end up doing a biopsy, particularly when there are the sole manifestations present without acute cutaneous lupus erythematosus. I tend to biopsy them. And they told, just like ALE, they also show typical dermo-epidermal junction infiltrate, and with hyperkeratosis, basal membrane vacuolization, and lot of dermal mucin. And very characteristically, IF shows dermoepidermal junction immunofluorescence. Then comes the DLE. DLE lesions are hyperpigmented plaques. They are plaques because they are elevated from the skin lesion surface. They have a central atrophy, epidermal atrophy, and they typically occur on the ear, behind the ear, on the scalp, like this case, extreme cases, or on the extremities. When it is DLE is present below the neck, it is called generalized, and generalized DLE is generally more specific for lupus, whereas DLE alone is seen very commonly in dermatology OPDs. Rarely they do come to us because only 5% of them have the underlying SLE. And histopathologically, see, all the histopathology is similar. You have perivascular lymphoplasmacytic infiltrate, you have dermoepidermal, very thick lymphocytic infiltrate, increased dermal mucin, and you will have immune deposits among the dermal epidermal junction on IF. But the severity of this varies. Generally, in case of DLE, it is much more severe infiltrate. Then you have varieties of intermittent cutaneous lupus erythematosus, lupus erythematosus tumidus. I've seen only 3 cases of them. These are fleshy erythematous plaques, and generally they have some lupus features, some arthralgia, some leukopenia, but majority of them do not have underlying major organ lupus. And lupus paniculitis, this is something again we come across where, disfiguring paniculitic lesions occurring. These are nothing but inflammation of the subcutaneous fat. So far we talked about SCLE or ALE or DLE. Most of them, all of them have predominantly the dermis or epidermis involvement. When it moves into the subcutaneous inflammation, then that's what causes paniculitis. And we know the causes of paniculitis is wide and vast. Some of them could be lupus erythematosus profundus or paniculitis. These typically resolve with scarring because there's a deep inflammation, and they are induced by irritative stimuli, and they are not photosensitivity. Remember, these are not a specific manifestation of lupus. So there are many patients who will have them without any SLE features. Then one interesting feature called chilblain lupus, where there is acro, painful tender nodules, typically on cold exposure. And again, these are not specific lupus lesions. Many of them get better with nifedipine. Only a very small portion of them develop full-blown SLE. And this is what I meant by common histologic pointers. There's a typical, for all SLE lesions, there is interface dermatitis. Interface means the area between the dermis and the epidermis. There is a hydropic degeneration of the basal layer, and dermal mucin is increased. And when you do a IF, you can see a strong deposit for IgG and C3 at the dermoepidermal junction. And these are present, and you call it as possible lupus-related skin disease. There are a number of other atypical features like lupus. It can cause alopecia, it can cause oral ulcers, it can cause leukocytoclastic vasculitis. But one key aspect in diagnosis of SLE is biopsy. And biopsy, when you move from acute to chronic forms, you will generally have a greater cell infiltrate, more dense lymphoplasmacytic infiltrate, more marked epidermal atrophy, greater hyperkeratosis, and scarring is more prominent in DLA. However, remember, interface dermatitis should not be labeled as SLE dermatitis. So this is another common thing that I come across. Patients with biopsy of some red lesions on the skin being labeled as SLE. You cannot, on the skin biopsy, you cannot say that whether it's SLE or not. All you can say that it is interface dermatitis, typical of SLE. It's for the clinician to make a diagnosis of SLE, because even malignancy, dermatolomyositis, drug reactions, all of them can cause interface dermatitis. Then coming to the articular manifestation, we know that typically SLE, as opposed to rheumatoid, we were discussing in the last session, is non-erosive. So these, although you can see the deformity, this is something called Jacquard's arthropathy. When you ask the patient to lie his hand straight on the, press against the hard surface, generally these deformities disappear. That is because of the weakening of the ligaments, which periligamentous inflammation, which is common in SLE. Knee joint is the most common joint affected in lupus. Constitutional features such as fever occurs in a large majority of the patient. Typically, it is associated with other manifestations such as rash, arthritis, ulcerations, proteinuria, alopecia. However, pain, fever being the sole presenting manifestation of SLE can occur in 5%. However, it's very rare. So a patient with only fever, nothing else, lasting for about 1 month or so, ANA probably should be avoided, because it probably leads to loss of false alarm and maybe loss of missed diagnosis, which can mimic pyrexia, which can cause pyrexia of unknown origin. One should strongly refrain from routine ANA testing in all cases of PO, unless you have other clues such as anemia, leukopenia, thrombocytopenia. Some neurological, it could be peripheral neuropathy, cranial neuropathy, myelitis, headache, or it could be pleural effusion, serositis, ascites, pericarditis, renal manifestation. Unless you have any combination of them, generally refrain from testing ANA. Coming to lupus nephritis, we know that there are 6 classes, and based on which place is involved. So minimal change disease, you can see only under electron microscope, where there is effacement of these food processes. This is something which only electron microscope can differentiate. Then minimal mesangial, where only tissues in the mesangium, you can get a deposition of immune complex. Then you have focal lupus nephritis, where a portion of endocapillary plexus, there is a deposition immune complex, and that causes proliferation. And then diffuse proliferation nephritis, when there are more than 50% of the glomeruli are involved. Further subclassification now includes diffuse global and diffuse focal lupus nephritis. And then there is a membranous nephritis, where there is subepithelial immune deposits. You can have a combination of subendothelial deposits and epithelial deposits, that's class 3 or 4 plus 5. Then advanced sclerosing form, where there is an absolute sclerosis of most of the glomeruli. So what important to remember, this is not typically the way in which lupus nephritis progresses. You can have a direct beginning from class 4, class 5 lupus nephritis without going other 2 stages. Generally, up to mesangial proliferative nephritis, we keep immunosuppression very minimal, just up to 0.25 milligram per kg of prednisolone and taper, whereas you need much more aggressive steroids and steroid-sparing drugs for further classes of lupus. Now, I want to touch upon one beautiful classification criteria. We are all aware of the ACR 1981. A slick criteria came in 2012, but the newer 2019 UCAM classification criteria for lupus involves ANA as the entry criteria. This is the most important thing. 1:80 or more is the entry criteria for lupus. So it's very hard to diagnose SLE in a patient who is ANA negative. Although you can have ANA negative lupus, but not such a common thing unless there's a great proteinuria or other things leading to ANA negativity. Typically, what you see is you accord different points for different domains, and as you can see, even within the nephritis, there are higher points given for more specific manifestation like class 3-4 lupus nephritis as opposed to class 2 nephritis. So here AMPLA antibodies, complement proteins, and lab parameters like DS, DNA, and Smith are retained, and you have classification across various domains, including constitutional, cutaneous, musculoskeletal, neurologics, serositis, hematological, and renal. This just represents the wide organ manifestations that are implicated in lupus, and this is how generally lupus behaves. Generally, lupus nephritis, although at presentation are present only in 40 to 50%, over a period of next 10 years, this number raises to 80 to 90%. So it's not very common to have a full-blown SLE lasting for 10 to 12 years without renal involvement. I might be having only 5 to 6 such patients in my follow-up over a period of 200 patients or that I manage. So that shows that lupus is truly multisystemic and it evolves over a period of time. Now, coming to the most important part, when a patient presents, as you see, the patients with lupus can be very non-specific. They can present with arthralgia, typical or very mild rashes on the malar area, or they can present with leukocytoplastic vasculitis or joint pains. Sorry. And they can present with serositis, or that is accumulation of fluid in the pleural cavity, or ascites, and a host of other manifestations. So when you're dealing with someone who presenting with this kind of multi-system involvement, the first and foremost important involvement, that's what I tell all my residents also, is look at the CBC, LFT, creatinine, ESR, CRP. Many a times this much gives you plenty of clues. For example, lupus is also always associated with low hemoglobin, low WBC count, and low platelet count. So someone who presents with fever, arthritis, and rash, maculopapular rash over the body, and his or her WBC count says 15,000 and CRP is 60, I wouldn't think of lupus in this patient, no matter even if the ANA is positive, because my first entry criteria was here itself. So I screen my patient when I practically make a diagnosis on basis of these things. Generally, lupus, many of them have anti-neutrophilic, anti-lymphocytic antibodies. They tend to have cytopenias. They tend to have thrombocytopenia. In fact, a very high platelet count should refrain from diagnosing lupus. And raised ESR, and because of presence of antipentoxin antibodies, they have a low CRP or normal CRP. So sometimes they say that whenever you have a joint involvement in lupus, and you have some fluid in the cavity, in the lungs or others, sometimes you can get raised CRP in lupus. But generally, it is only up to 15-20 milligram per liter. A very high CRP, say 200, 300 in a critically ill patient, don't think of SLE as the sole manifestation. It's either SLE with infection, or there's one more conduction where in SLE you can get such high CRP, something called macrophage activation syndrome. But these are very rare manifestation of hyperinflammation. Generally, you should not have high CRP in lupus. Lupus, when it's active, generally has some amount of transaminitis, decreased AG ratio because of the raised globulins. They can have normal deranged creatinine. urine routine is absolutely crucial when you have a patient who present with multi-system involvement. Proteinuria along with casts or RBCs is highly suggestive of as major autoimmune process such as lupus going on. And I mentioned during pathogenesis of SLE that there is excess consumption, excess of apoptosis, and that result in excess generation of complement activation, and that result in low complement. So low C3 and low C4 are very characteristic of lupus, particularly low for C4. So sometimes in chronic infections like by endocarditis or TB, you can get low C3, but low C4 is very specific for a major autoimmune disease such as SLE or its sister diseases such as Sjogren's. So in a critical patient, this is a very important table that one need to remember that remember infection versus disease. And it's always a dilemma for us for a period of managing lupus, at least about 5 to 6 episodes of major infection every rheumatologist generally encounters. And this is how generally we approach these patients. So in a fever in a sick lupus patient, remember, SLE onset of disease activity is generally over days to weeks. Over hours to days, if the patient deteriorates, it's more likely infection. Fever tends to be very high grade in infections. WBC count in infection is elevated. In lupus, it generally goes down. Complements, both C3, C4 are very low in SLE activity. Either in infection, they are normal or only low C3. This factor I mentioned, only ESR raises CRP remains normal, whereas a very prominent CRP of 180, 200, always think of an infection. It is a very practical problem. So whenever you have a patient with SLE present with severe pain abdomen, and it could be due to disease activity, ascites, but if you have that kind of a CRP, even more than 50, 60, think of tuberculosis or other infections. Procalcitonin, as usual, it is quite useful in many bacterial infections. Urinalysis generally shows cast or hematuria in nepus, pyuria in infections, and anti-DS DNA are elevated if there is a disease activity. Only after when you go through all these things, you come to ANA. It's not something which I focus as the first line for the reasons I'll tell you. ANA, remember what is it? Is as the name itself says, it's anti-nuclear antibody. So basically, it detects all those proteins in your serum which have a activity against the nucleus of a cell. So anything which acts against this is anti-nuclear antibody. But over that time, this definition has now evolved to include even those antibodies which are active against the cytoplasmic component of the cell. These cells are Hep2 cell lines grown in a medium, and you basically put your serum on them and see if you have this, your serum has activities against the antigens present in the nucleus or cytoplasm of this Hep2 cell. So it's more of an anti-cellular antibody rather than an anti-nuclear antibody. Then a popular question is solid phase assay like ELISA or IIF. So a rheumatologist will always say that it is going to be immunofluorescence because we are going to see a lot of more information rather than just ANA positive or negative. I'm going to get a pattern of ANA, something like homogeneous pattern is more likely to be associated with SLE rather than others. And also you get to know what is the antigenic target. You can have the target in the cytoplasm in which anti-cytoplasmic antibodies are less likely to be associated with SLE and more likely to be its common mimics, that is infection, malignancies, and drugs. So that is why we always as rheumatologists say that when you order ANA, remember to order ANA by always bracket immunofluorescence. But as saying that solid phase assays like ELISA are highly specific. Now, when I started my residency in MD, I used to know about only a couple of patterns about ANA. So one is homogeneous, one is speckled, where there's speckling, and then there is a centromeric pattern, and These are the 3-4 patterns that I remember, and nucleolar. But now there are more than 28 patterns of ANA, and this is what you keep getting in some of the reports like AC11, AC13. These are nothing but where the antibodies are targeted. As you say, it's very simple. The methodology of ANA testing is very simple. What they do is, in a Petri dish or any dish, they place these cells. These cells are nothing but Hep2 cells. These are cancer cell lines. So I expand one of the cells like this. So one of the cells will look like this. And this cell has a nucleus, and it has a cytoplasm, and it may be dividing, so in which it has dividing apparatus with other cell. So that is mitotic apparatus. So depending, what happens is, you are going to put your serum onto this, and if your serum has some proteins, that is antibodies against this anti-nuclear or anti-cellular, they bind to this, you wash the unbound thing and detect the immunofluorescence. They are going to tag these antibodies with some material which is going to light up when you view under a microscope. So you are going to get different patterns. So what is mean by nuclear pattern is, the immunofluorescence is here on the center of the cell, whereas cytoplasmic means it is around the cytoplasmic dots, fibrillar, speckled, others, and mitotic patterns means the dividing cells. So this is how you differentiate different ANA patterns. See, I'm putting up this because a lot of labs have started reporting, like they start reporting AC15, and it's just creating more confusion than any kind of solution, I feel. But that's the nature. This is the internationally accredited pattern of ANA reporting, and that's why more and more microbiologists would also start returning, and you should know basics about what you mean by this pattern. Now, each of these patterns have different pathologies associated with it. This is what I meant. I mean, I'm going to put a specimen here, and if there's an antibody bound to this fluorochrome, it is going to be detected when you're going to see under the microscope, and that is what finally is going to give you a fluorescence like this. So this is indirect immunofluorescence. That is what we use, IIF. We use for ANA detection. Basically, tissue plate containing the antigens is placed, and if your serum contains this antibody and it's going to bind to this, that pattern, what we're going to see, and the pattern will also depending upon the which cells are signed. So this is a typical cell signs. Again, in a difficult, when you see under microscope, you are going to see various forms of cells. Some cells are dividing, some cells are not dividing, and all of this is important to report ANA patterns. But remember, always interpret in clinical context the ANA. This is probably the most important slide of the talk. So there should be something called pre-test probability before ordering any immunological test, particularly ANA, because it is so often positive in normal people also, particularly at lower dilution. Suppose, forget about all this, there is a young woman with just some mild arthralgia and hair loss, then it's not, and there is nothing else on examination. This passes for 2 years or more. My probability in her is only 1%. So even if I test a positive ANA, then also my post-test probability is only going to be 6%. As opposed to, suppose a patient presenting with photosensitivity, fever, inflammatory arthritis in a female who has leukopenia, my pre-test probability is almost always about 90%. And if the ANA comes back positive, it's going to become something like 99% sure. So this is the most important thing, that have some semblance of pre-test probability in your mind before ordering the ANA by F. Otherwise, the problem with this is it can be positive in normal population to a great extent. One of the Bangalore labs reports ANA 1:40 dilutions. If you keep doing 1:40 dilutions, I mean, what do you mean by dilution is, you should, at greater amount of dilutions, you should get that immunofluorescence. At 1:40, you are putting a very concentrated solution of the patient onto the serum. And at this titer, 1:40, you get around 30 to 40% of the normal population with positive for ANA. And that's why I see 1 plus ANA positive at 1:40, it has absolutely no meaning. I used to report it as residencies, and I always report only ANA positivity at 1:100 or above. Below that, it doesn't make any sense to me, because many normal people will have, and this positivity comes down with increasing dilution. As you can see, something which was about 38% and above, when you concentrated the solution and checked at 1:30, 320 dilutions, it came as 3.3% prevalence. So ANA has to be tested in serial dilution for it to be clinically meaningful. Only when you test the dilutions and all, then comes the a pattern analysis. This is the cell phase I was talking about, and we need to know about the prophase, metaphase, anaphase, telophase, and interphase, because that is how we are going to identify the pattern. So about 80% of the patient's cells in a ANA plate will be in interphase. They are looking like this, with very minimal cytoplasm around them. And when you see a homogeneous staining with a strong positivity for metachromatic plate that's homogeneous, this is typically seen in SLE. Then you have speckled appearance with non-staining of the metachromatic plate. It can be fine or coarse speckled, associated with MCTD or Sjogren's respectively. Then you have the anti-centromere antibodies when you have 46 dots visible like this. So that is why we say NA by IF, because not only we get to know about the positivity, but also the pattern. Anti-centromere antibody, I know that it is anti-centromere antibody which is present. I will not order an NA profile. I know that this is associated with limited scleroderma. So these are the various patterns. Then we have cytoplasmic patterns, which are generally associated with dermatomyositis, infections, malignancies. Only after this, we come to ANA profile. Remember, ANA profile is not more specific than ANA by IF. We always try to go by ANA as the first screening test. Yes, many times when the diagnosis is very typical, for cost reasons, I will not always order ANA profile. What ANA profile is going to do is, again, you are going to expose your serum to these various strips containing these antigens, dsDNA at separate point, or SCL70 at separate point, and run the patient serum. And if it forms precipitation here, that is showing as shows up as positive. Remember, borderline positivity for this PCNA and various other antibodies also may be very common in the population. Only thing, it's not very easily studied. Unlike ANA positivity, we don't know what proportion of normal population are positive for dsDNA or SCL70. So when you don't know, you should not order this test unless there's a very strong clinical background. Otherwise, again, you are going to end up with confusions rather than answers. So this is how a typical diagnosis of lupus would involve for me. It would be a young female in her 20s or 30s, presenting with fever, rash. I told you mala rash, very typical, or SLA rash, and arthralgia or arthritis. And when I looked into the routine test, I find mild anemia, 3,600 around of TLC, platelet of 80, 90,000, and raised ESR, say 60, 17, CRP negative, and urine showing 1 plus protein. This is how a typical lupus patient will evolve into. This all combination gives me a very strong probability of lupus. Only then I will order ANA by IF. Say a 56-year female coming with knee joint pain for about 2 years, presenting worsening on activity, should not order ANA, because if you order ANA, you can get, even at her age, 1:100 titer, you can get about 5% positivity. Now you don't know what to do with this in 5% of the patients. So that is why always order immunological test in a good clinical and lab context. Management, I'm not going to spend too much time on. Typically topical steroids, topical calcium inhibitor for lupus. We all know that cutaneous lupus, we use sunscreen with SUV fraction of more than 19 because that cuts off about 95% of the UVB rays. And we use antimalarials like hydroxychloroquine, which is very important. The treatment landscape for SL is absolutely evolving over a period of time. We can interrupt many steps in pathogenesis, right from APC T cell interaction to B cell depletion. And we have cytokine blockers. All of this have been tried, and probably I would dare say that SLE is the disease where up until last 3-5 years, I think we had seen the maximum number of failed trials. You typically end up with only 1 or 2 positive trials out of hundreds of lupus trials. So up until about 2014-15, I think 2012-13, sorry, if you believe or not, only HCQ and steroids were FDA approved drug for lupus, nothing else. Only now we have belimumab, anifrolumab, and voclosporin. A large number of drugs that we use, like MMF, methotrexate, rituximab, even cyclophosphamide, they're all non-FDA approved because they have all failed their trials. But that doesn't mean that we should stray away from these drugs, because these are the drugs which are absolutely life-saving, and in practical sense they make a lot of importance. They could be B cell depleting agents like rituximab, obinutuzumab, ocrelizumab, survival inhibitors like belimumab. This is already approved, but it's not available in India. And then plasma cell inhibitors, bortezomib, where I've ended up using few patients where lupus was coexistent with plasma cell dyscrasias. This is just a figure to highlight the disappointments that we have. Even a drug like rituximab, which we all pledge by as one of the most useful drugs for lupus, has failed trials in both renal and non-renal lupus, that is LUNAR and EXPLORER. This is a picture depicting the various trials, and you can see that belimumab has significant response of active comparator group of plasma, and this is an approved drug now, and there is various other drugs. Now recently we had positive trials for voclosporin, that's Aurora. It's an oral molecule. It's a calcineurin inhibitor similar to tacrolimus, but difference in efficacy and differently efficacious and maybe more safer. It's shown excellent reports in renal lupus remission, but but it's not available to India, unfortunately. Then we have anifrolumab, which is an interferon receptor blocker. Again, it has shown a superiority of the active arm compared to plasmo. This is the drug trial published in Inigium. And based on this, we have these 2 drugs, particularly for cutaneous form. It's excellent, but unfortunately, it is not available in India. So I'll not dwell too much into treatment aspect of it, but just a slide showing our general approach for non-renal lupus. We concentrate on sun protection, exercise, no smoking, vaccination, and normal blood pressure, weight loss, and others. And we always try for remissions with SLEDAI of 0. Otherwise, LLDAS is another treat to target in our case. And we use HCQ. That one dictum for lupus is HCQ throughout unless contraindicated. And as required based on the manifestations, we use methotrexate more for joint and skin manifestations, MMF, azathioprine for renal or gastrointestinal manifestations. These two drugs are excellent, but we don't have anifrolumab and belimumab. Then tacrolimus, cyclosporine, again across musculoskeletal, renal, and cutaneous forms. And generally, renal threatening, life threatening, we go for cyclophosphamide or rituximab. Lupus nephritis, generally first line treatment is steroids with MMF or cyclophosphamide, practically right now. And if that fails, then we go for rituximab. And generally, we target a partial renal response by 6 months, that is more than 50% reduction in proteinuria, and complete renal response defined as proteinuria of less than 700 to 1 gram per day. And that generally should be achieved within 12 months. That's the treatment target we have for lupus. So coming to take-home message, it's a complex autoimmune disease, SLE. There's no single test, no single algorithm I can give to diagnose of lupus. And when in doubt, always keep the diagnosis open-ended. I mean, I have a lot more patients with undifferentiated connective tissue disease rather than SLE. These are the females who have some arthritis, definite arthritis, or who have some Raynaud's, or who have some dryness, sicca, who have mild WBC count fall, and strong ANA positivity. But unless they are meeting the criteria for lupus, for me, criteria for lupus includes full-blown lupus rash. I'm not talking about the classification criteria. For a clinician who is treating, I mean, he's at his free will to use the classification criteria. I go generally like this. I mean, when a patient has all of these, like typical rash or with proteinuria or renal involvement, or only when there is major organ involvement like CNS involvement with low complement, I tend to go for diagnosis of lupus as SLE. Otherwise, those who have NA positivity and arthritis, just keep the diagnosis open-ended as undifferentiated connective tissue disease and treat. Do not label them as SLE, because if you label them as SLE, then you might lose, confuse the next person looking at you, and they might not try to evaluate this patient should something else develop. And I have n number of these patients where I labeled as undifferentiated connective tissue, and later on, turning out to be a lymphoma, a malignancy, an infection which we missed in the first place. So all these things are possible. So unless they're meeting the criteria in terms of full-fledged thing, keep it as undifferentiated connective tissue disease and treat the manifestations. We generally make a diagnosis based on clinical and lab. ANA positivity is never equal to SLE, even in high titers. Assess organ involvement and treat. And even within SLE, I treat a SLE involving kidneys very differently from SLE involving musculoskeletal plus cutaneous manifestations. Here I might be using only HCQ methotrexate. Here I'll be more inclined towards MMF or cyclophosphamide. So this treatment also varies according to the organ manifestations. With that said, we conclude this presentation, and thank you.
Thank you, Dr. Abhishek, for a very extensive presentation. It was, very insightful, especially the pathogenesis. You can keep your video on now.
Yeah, ma'am.
Just
come back.
Yeah.
I don't know where
I don't see any questions on the chat box.
Yeah,
but one comment from my side.
Yeah.
I lost my father-in-law to SLE in 1991-92. I'm talking about those days when the suspicion was not much. I had ordered, depending on the symptomatology, I had ordered it myself at Anand Lab, and the reports used to take more time those days, almost 5 to 7 days they used to take. So after he expired, 3 days later, I got a call from the lab saying that he is SLE positive. And there was no suspicion. He had GI involvement and renal involvement. So GI biopsy did not show anything very clearly. There were ulcers in his intestine. And just looking at his varied symptoms, I had ordered for it. discussed, of course, I discussed with the gastro. He said, yeah, get it done, maybe, though it is not very typical. And later he developed renal symptoms also. But he had only one solitary rash on his tibia. Nothing more than no rash, nothing. And that biopsy did not come out very specific for SLE at all.
No, I mean, the biopsy generally doesn't, I mean, it's a clinical.
Yeah.
And very unfortunate to hear this. Sorry for your loss. But I mean, particularly males, I mean, there are so many aspects to cover in SLE. I couldn't have possibly covered it.
Yeah, I know. It's a very extensive topic.
But male SLE is something which is very rare, but it is very aggressive. That's something which we realize that it behaves, particularly when it occurs at an elderly age group and in males, it behaves very aggressively and doesn't give you any time. This is the thing that we have
all
seen.
This happened over a period of 1 to 3 months. That's it.
And now, at least, fortunately, the awareness about this is increased.
Much more.
Although the full-blown SLE is not very common, maybe 10 per million or so, but the milder forms, undifferentiated connective tissue disease, other major autoimmune disease are quite commonly seen. And it's important to understand why this pathogenesis occurs and how to interpret these tests, because the tests are available very easily. That's another issue.
So I have a question for you, Dr. Abhishek. 1 minute, Dr. Sanjay. When there are comorbidities or there are concurrent some infections or some other problem. I had a case of SLE whom I had to take care during COVID. She was under my care through Apollo. And she was on treatment for SLE. And, she was so scared to take even a paracetamol without discussing with the rheumatologist. So some light upon what are the other drugs which we can, drug interactions, what we can use.
Ma'am, I think it depends typically on the drugs that you are using for SLE. Typically, what we use: hydroxychloroquine, methotrexate, mycophenolate, cyclophosphamide. Fortunately, not too many drug interactions. And SLE, the major mortality, in fact, is with infections, not with the disease itself. So these patients also, because of their altered immune system, have a much higher risk of infections. And along with on the background of immunosuppressive therapies, which many of these patients are on long term. So you need to be a little bit more aggressive in general in evaluating these patients for infections and treating. And what I have seen, practically the patients of lupus whom I have lost, lesser number of them are due to disease itself rather than to the infection. So don't be hesitant. Whenever you're in doubt, keep the steroids on, hydroxychloroquine on, but go ahead and treat them aggressively and evaluate for infections, particularly when the features are on. And I think I highlighted that point. Whenever you have a very sick-looking patient with high-grade fever, very high WBC count, elevated CRP. CRP is one of the most crucial things I use in lupus patients to differentiate disease activity with infections. Very high CRP, not too much of activity in the urine. Think of infections more. Do cultures, treat them with empirical antibiotics as per guidelines, and you can withdraw the immunosuppression, keep the steroids on. And IVIG is also one excellent option when you are in doubt whether it's disease. And that problem also we have faced, where infections versus disease activity I have faced. And it can be both also. Unfortunately, an infection can trigger an SLE attack very easily. In fact, many of the viruses like EABV, CMV infections can trigger an episode of lupus activity. In such cases, when both are there, IV immunoglobulin is one excellent option for these patients.
If you have any questions, Dr. Jyotika.
Sir, after listening to Abhishek Patil, I think SLE is not a cup of tea of a family physician, but diagnosis of SLE is important. Is there any specific test, sir, for diagnosing SLE? Specific test?
Unfortunately,
or we have to see clinically and some.
So generally they say that as I mentioned, low complements, particularly low C4, highly suggestive of a major connective tissue disease, be it SLE, Sjogren's, or other things. So that's one important marker, low C4. C3 can be low even in chronic infection, but low complements, always think of this. And also anti-dsDNA ELISA method in high titer. So this is also quite specific for lupus, particularly when it is present in significant titers, at least 3 times the upper limit of normal. So dsDNA when cutoff is 25, and if it is 27, it may not be important. But remember, one of these important things, I think I made a mention about this, rheumatoid, anti-CCP, or when these major autoimmune diseases are there, and these antibodies are there, generally they are in full titer. Either they're there or not there. So anti-dsDNA, most patients with lupus active, you will find more than 200, these kind of values, because that is the pathogenesis. They are directly involved in the pathogenesis of lupus. So your B cells are proliferating. They are producing more amount of anti-dsDNA. Whereas when you get, the way these tests are conducted, if you know the details, I mean, lot of false positivities can occur in ELISA. So patient may not have anti-dsDNA, but maybe picked up a borderline 25 with cutoff 25, 27 positivity for dsDNA can come because of the lab error, and honest lab error. It's not that the lab is wrong, but these are because this is the photo plate which is projected into a value. So I don't want to go into depth of that. So a lot of background noise can produce that kind of borderline positivity for antibodies. So if you ask me, high titer dsDNA positivity, low complements, low WBCs, low platelet, high ESR, low normal CRP, these are quite good markers to think of lupus lab-wise.
Like Dr.
In
Sanjay.
short, what is the prognosis?
So
what is the prognosis of SLE patient?
So nowadays with modern treatment available, it has improved, but it has plateaued also. I mean, from it has improved significantly with use of cyclophosphamide, MMF, and others. But over last 2 decades, we have not seen the mortality improvement with lupus. Probably the newer drugs will bring about the push that we need when they are available. We desperately need this voclosporin and anifrolumab and belimumab in India, because I know that when I see a patient with lupus, I don't see just as SLE. I just see whether this is an SLE with IFN being the interferon being the prominent cytokine, whether it's SLE with B cell as the prominent disease based on the manifestation. So in those few patients where mainly it's an interferon mediated disease, I want those newer drugs which are not there, unfortunately, with us.
So no questions on the chat box. Like Dr. Sanjay said, I think everybody feels that SLE is the domain of a rheumatologist. So not too many doubts. And you were very, very explanatory. The pathogenesis was very, very clear. Dr. Jyotika, if you're free, if you have any comments, or we'll end the session. We are already running 15 minutes late. Yeah, I think Dr. Jyotika is busy. Okay. Thank you. Okay.
Thank you.
Go ahead. Thank you very much, Dr. Abhishek, Dr. Sanjay, Dr. Jyotika for joining us. And thank you for the back-end team. And of course, the viewers, thank you very much. Without you, we will not be here. It is all for you all. And thank you very much, sir. We'll be back again next week, same time, 29th. The topic, we'll be putting up the topic and the link soon.
Sure. Thank you.
Thank you very much. Thank you, sir.
Okay.
Praful, you can end